Primary bone tumors represent less than 0.2% of all neoplasms. However, among children and adolescents, malignant variants are the third most common cause of cancer-related death. Diagnosis is often delayed because the initial symptoms are nonspecific. Patients present with persistent bone pain, restricted joint movement, or a palpable lump. A high degree of clinical suspicion is required when a patient reports persistent pain at night. Because these symptoms often follow minor trauma, they are frequently misattributed to sports injuries or benign groin pains. If the condition is allowed to progress, imaging often reveals a gross lesion, such as this primary cancer situated on the tibial shaft. These clinical overlaps make physical examinations unreliable for definitive diagnosis. While a biopsy is necessary to identify the pathology, the extracted tissue introduces a secondary set of complications for the laboratory. Once the biopsy is processed, pathologists must navigate significant diagnostic ambiguity. The central challenge is morphological mimicry. In bone pathology, aggressive malignancies and benign reactive processes often appear identical under a microscope. A benign fracture callus can histologically resemble a high-grade chondroblastic osteosarcoma. Similarly, the cellular architecture of a benign aneurysmal bone cyst often parallels that of a lethal telangiectatic osteosarcoma. Relying solely on cellular appearance risks catastrophic clinical errors, leading to the unnecessary surgical resection of benign tissue or the undertreatment of a high-grade sarcoma. To resolve these ambiguities, pathologists must look past the cellular structure and identify the underlying molecular drivers of the tumor. Modern diagnosis uses a matrix that categorizes tumors by lineage and genetic alterations. The bone-forming column includes benign variants like osteoid osteoma and medullary-based osteoblastoma. The malignant counterpart is high-grade central osteosarcoma, identified by the production of lace-like osteoid. A major shift in our understanding of pediatric osteosarcoma is the prevalence of germline alterations. Data indicates roughly 20% of young osteosarcoma patients harbor a predisposition through an underlying germline mutation. These include TP53 mutations in Li-Fraumeni syndrome and RB1 alterations in hereditary retinoblastoma. Confirming these alterations changes the scope of clinical care, as the discovery necessitates genetic counseling and screening for the patient's family. The second pillar of the matrix covers cartilage-forming tumors. In this group, solitary enchondromas are benign, but multiple enchondromatosis, such as Ollier disease, carries a risk of malignant transformation as high as 30%. Differentiation between these forms is achieved through specific molecular testing. Over 90% of Ollier and Maffucci cases are confirmed by IDH1 or IDH2 somatic point mutations. If these mutations are absent, pathologists screen for rarer forms of the disease associated with the PTPN11 or ACP5 genes. We must also consider chondroblastoma, identifiable by a microscopic chicken wire pattern. This diagnosis is solidified by H3F3A or H3F3B somatic driver mutations, present in over 90% of cases. Using these specific molecular markers provides a definitive rule-in for benign tumors, preventing the morbidity associated with aggressive cancer treatments. The third column categorizes fibrous and osteoclast-rich lesions. Fibrous dysplasia presents as spindle cells containing irregularly curved woven bone, often lacking an osteoblastic rim. To confirm this over a low-grade osteosarcoma, pathologists test for somatic point mutations in the GNAS gene. Primary aneurysmal bone cysts are identified by their blood-filled cavities and a characteristic USP6 gene rearrangement. However, cystic changes can also occur secondary to other neoplasms. These secondary cysts can expand rapidly, potentially hiding an underlying high-grade malignancy like telangiectatic osteosarcoma. A cystic lesion lacking the USP6 rearrangement suggests a secondary process, necessitating a wider biopsy to identify the primary tumor hidden by the cystic expansion. The fourth column contains small, round blue cell tumors, the most morphologically ambiguous group in pediatric pathology. Under a standard microscope, Ewing sarcoma, lymphoma, and metastatic neuroblastoma all appear as identical sheets of blue cells. Because histology is nonspecific here, diagnosis depends entirely on immunohistochemistry and fusion genes. Over 90% of Ewing sarcomas are defined by a specific EWSR1 FLI1 translocation. Without cytogenetic confirmation, establishing a treatment protocol for these tumors carries an unacceptable risk of misdiagnosis. Relying on descriptive morphology alone provides an incomplete and potentially dangerous assessment of pediatric bone tumors. The visual similarities between reactive processes, benign tumors, and high-grade sarcomas make molecular verification essential for diagnostic accuracy. This precision dictates clinical strategy. For instance, a confirmed chondroblastic osteosarcoma requires neoadjuvant chemotherapy, whereas a true chondrosarcoma does not respond to such treatment. Because of these complexities, pediatric bone lesions should be assessed in specialist referral centers, where pathologists can integrate clinical history with advanced cytogenetic testing. By integrating molecular subtyping with the identification of germline risks, pediatric pathology has moved toward a model of higher diagnostic certainty and personalized clinical management.